The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. My name is Hunter Lyles, and I'm a paralegal at Lyles Parker. Thank you for joining us for our monthly webinar Wednesday series presented by Lyles Parker and sponsored by Texas Association for Home Care and Hospice. Today's topic is Medicare, Telehealth, and Telecommunications Technology in Home Health and Hospice, hosted by Ashley Morgan and Mary Soule Cutler. With the advent of COVID-19, CMS has taken a number of steps to make it easier for patients to be treated remotely using telehealth. Many home health and hospice agencies have expressed interest in this treatment approach and are still evaluating whether or not to implement its use in their agency. Unfortunately, there is a lot of confusion with regard to the use of telehealth when providing home health and or hospice care. During this webinar, we will try to address a number of questions in this regard. Join attorneys Ashley Morgan and Mary Soule for discussion the current home and healthcare and telehealth environment and risks that your agency may face should you choose to employ this type of care. Ashley Morgan is a senior counsel at Lyles Parker. She represents healthcare providers across the country in connection with a wide variety of healthcare law issues, including coverage disputes, documentation concerns, compliance, medical board complaints, revocation and exclusion/termination issues. Ashley has worked with an assortment of providers, including dentists, home health companies, hospice agencies, primary care and specialty physicians, mental health professionals, physical therapists, and licensed acupuncturists. Ms. Morgan is a certified professional coder, certified medical reimbursement specialist, and a certified medical compliance officer. Mary Soule Cutler is an associate attorney at Lyles Parker. She focuses her practice on regulatory healthcare compliance matters, fraud and abuse, and reimbursement issues. Mary has represented a variety of healthcare providers, including home health agencies, primary care physicians, psychiatrists, dentists, and acupuncturists. She represents healthcare providers nationwide with an assortment of health law issues, including prepayment and postpayment audits with Medicare, Medicaid, and private payers and general compliance matters. She is a certified medical coding specialist and a certified medical reimbursement specialist. With that being said, let's get started.
All right. Thank you, Hunter. Can you share your screen, please? Yes. So everyone can see the slides. There we go. Great. Thank you. I'm looking at it on my end, but realized that y'all weren't seeing what I was seeing. Hunter, would you mind going to the next slide, please? So just wanted to kind of give a brief overview of what we're going to discuss today. With our introduction, we're just going to go through kind of the basics of what exactly are, telehealth and telecommunications. And then we're going to discuss the COVID-19 pandemic and Medicare's approved use of telehealth, their expansion of telehealth. Then we'll discuss some of the security and HIPAA concerns that comes with the use of telehealth services. And then we will have a question and answers section at the end of the presentation. Hunter, next slide, please. So telehealth and telecommunications. So the literal definition of telecommunications is a communication over a distance by cable, telegraph, telephone, or broadcasting. However, obviously, that is not necessarily how we use telecommunications in the healthcare industry. And specifically under Medicare, telecommunications requires for almost all services an interactive telecommunications system, which means it must include, at a minimum, multimedia communications equipment that includes audio and video equipment, permitting two-way, real-time interactive communication between the patient and distant site physician or practitioner. So I've included the citations where this is found. I will note that there are some exceptions to this rule where telephone visits do qualify as telecommunication and as telehealth services. However, they're so few and far between of what's actually covered that in order to be safe and for the sake of our presentation, telecommunications is going to be the more general Medicare definition, which requires both audio and visual two-way real-time interactive communications. I will also note that this is the same standard in Texas Medicaid. So it's important to check state laws to just make sure that you're following that with regard to when you're providing services for patients who are covered under Medicaid and the state payers. However, because this is a presentation on Medicare and the federal, this is really going to be the only mention of Texas state law. So make sure that you do take a look at that. Telehealth is the use of telecommunications to provide care to patients remotely. So some examples of telehealth services include health education services, remote monitoring of vital signs, or blood pressure, and what we think of as telehealth with like a clinical, physician having a visit with a patient. So the difference between telehealth and telemedicine, you will see this phrase used interchangeably a lot. However, telehealth really is the phrase that's used by Medicare, and telehealth encompasses telemedicine services as well. Telemedicine services refers to remote clinical services such as a physician visit, while telehealth encompasses both clinical services and administrative and non-clinical services, such as the education that we were mentioning earlier and monitoring of vital signs. And as I said, for the purposes of this presentation, we'll be using telehealth since this is the term of art used by Medicare and its regulations. Hunter, next slide, please. So COVID-19 protocol for telehealth services. Unfortunately, we are a year into this pandemic, which has brought a lot of stress for, I'm sure, everyone involved, and has brought a lot of change with regard to how services can be provided during this unprecedented time. Because of the nature of the pandemic, Medicare did implement some emergency regulations that were to be temporary measures, though at this point we are now going on a year. So starting in March 2020, CMS expanded the use of telehealth services for the duration of the COVID-19 public health emergency, which we are still currently under as of the Department of Health and Human Services Secretary's declaration of the continuation back at the end of January. Patients can be anywhere in the country. They don't have to go to a healthcare facility. Physicians and non-physician practitioners can be anywhere, including in their office or in their home. New and established patients were able to be seen via telehealth, and home health agencies were also granted the use of Section 1135 telehealth waivers to provide telehealth services to patients. So when this was first started, HHS OIG did note that they were going to exercise enforcement discretion and waive penalties for HIPAA violations during this time. Because now there were healthcare providers who hadn't previously used telecommunication services to provide telehealth services, now all of a sudden doing so. The Office of Civil Rights at HHS said that they would use their discretion in determining whether there were HIPAA violations for people using Zoom or other not necessarily HIPAA certified telecommunications device. Hunter, can you go to the next slide, please? In November 2020, CMS did make these telehealth services regulations formalized into regulations for home health services specifically. Effective January 1st, 2021, a patient's plan of care must include any provision of remote patient monitoring or other services furnished via a telecommunications system in order for telehealth services to be covered under home health. So this is a continuation of the flexibilities that were allowed back in March 2020. It allows home health agencies to provide more services to beneficiaries using telecommunications technology within the 30-day period of care, as long as it's part of the patient's plan of care, and it does not replace needed in-person visits as ordered on the plan of care. The final amended regulations also state that the services must be tied to patient-specific needs as identified in the comprehensive assessment. So telehealth services really should only be being provided to patients where their physicians have noted in both the plan of care and has been noted in the patient's comprehensive assessment the need for those services to be delivered via telehealth. The regulations that were published in November 2020 further state that telehealth services cannot substitute for a home visit ordered as part of a plan of care and cannot be considered a home visit for the purposes of patient eligibility or payment. Hunter, next slide. So starting in late January 2021, HHS OIG announced that it was going to be conducting an audit targeting the implementation of Section 1135 telehealth waivers by home health agencies during the COVID-19 public health emergency. Now, a couple slides back, I mentioned this Section 1135 waiver, and how that was how home health agencies were able to use telehealth services. So I'm going to provide a little more information on what exactly is a Section 1135 telehealth waiver, and how that was used during this time. So the Section 1135 waivers during a disaster or a public health emergency, as so defined by the President, the Secretary of Health and Human Services can use Section 1135 of the Social Security Act to temporarily waive or modify certain Medicare, Medicaid CHIP requirements to ensure that sufficient healthcare items and services are available to meet the needs of individuals enrolled in these programs, and that providers who give such services in good faith can be reimbursed and exempted from sanctions, absent any determination of fraud or abuse. So as we discussed on the previous slide, these temporary regulations that were put into place that allowed home health agencies to use telehealth services was finalized. So now the services that they previously were using these Section 1135 waivers for, now you don't need the waivers because it is permitted under the regulations, you know, when the certain criteria is met. What we see with this audit that is now going to start is that HHS OIG is already getting into taking a look at the all of the waivers that were issued last year and the telehealth services that were provided by home health agencies. So even though back when the emergency was declared and this was started, and HHS Office of Civil Rights said that they were going to be exercising their discretion when it comes to the use of this, we now see HHS OIG is looking into the use of these waivers and telehealth services to see what exactly was provided. So according to HHS OIG, we will evaluate home health services provided by agencies during the COVID-19 public health emergency to determine which types of skilled services were furnished via telehealth and whether those services were administered and billed in accordance with Medicare requirements. So even though this was permitted, you know, unfortunately, HHS OIG is now going in and auditing these services to see how exactly telehealth services were used by home health agencies during the pandemic in 2020. Thank you. So as of March 2021, home health agencies can use telehealth services in the following circumstances: if the patient's plan of care permits the use of services provided by telecommunications and that they do not replace needed in-person visits. Our recommendation for home health agencies is to use telehealth services sparingly for your home health services. So again, unless your physician for the patient specifically writes in the plan of care and orders that certain services are provided by telehealth, we would recommend that you do not use telehealth services, in part because we believe that this will be targeted by HHS OIG and by CMS, as evidenced by the fact that there's already an audit being started by HHS OIG, and just this year alone. We just want to make sure that minimize the likelihood that you may be audited for the use of these services. Next slide. So telehealth use for hospice, I know we've talked a lot about home health agencies, and that is in part because the home health agencies have actually had the use of telehealth services put into law, put into the regulations. But as mentioned previously, hospice providers have also been allowed to use telehealth services during this public health emergency. So since we are still under a public health emergency, you are able to provide care via telecommunication systems in accordance with the temporary regulations. And so as of now, as of March 2021, CMS regulations have not been amended to make these changes permanent for hospice providers. So it is important to keep that in mind and to be aware that, once this public health emergency ends, unless you've heard otherwise, that also will end the ability to use the telehealth services in the way that's been permitted under the temporary regulations during this pandemic. So it is important to keep notice, to watch the news, make sure to see whether this does become amended for regulation. What we have been seeing is that it likely will be added into the law, but as of now, it hasn't been. So it is important to remember that these are temporary measures for hospice providers, and that once the public health emergency ends, telehealth services as currently permitted may no longer be allowed. But as of now, hospices may provide interdisciplinary services via telecommunication systems as long as the patient is receiving routine care, routine home care level of care. So during this public health emergency, CMS has amended the hospice regulations at 42 CFR 418.204 on an interim basis to specify that when a patient is receiving routine home care, hospices may provide services via telecommunication systems if it is feasible and appropriate to do so to ensure that Medicare patients can continue receiving services that are reasonable and necessary for the management of their terminal illness and related conditions without jeopardizing the patient's health or the health of those who are providing the services. Oh, no, sorry, Hunter, please, thank you. To appropriately recognize the role of technology in furnishing the services under the hospice benefit, the use of the technology must be included in the plan of care. So as we've discussed with home health agencies, where telehealth services can only be provided if the patient's plan of care explicitly allows for it, we're seeing the same with hospice. The patient's plan of care must explicitly allow for the use of telecommunications and for telehealth services. And it must be tied to patient-specific needs as identified in the comprehensive assessment and the measurable outcomes that the hospice anticipates will occur as a result of implementing the plan of care. So it will allow the use. CMS amended the regulations temporarily under the public health emergency because they wanted to ensure that telemedicine and remote patient monitoring would be able to be used for patients to receive those necessary services without jeopardizing their health or the health of hospice employees. Next slide. So for the purposes of the hospice claim submission, only in-person visits should be reported on the claim. As of the CMS guidance that was published in April 2020, hospices can report the cost of telecommunications technology used to furnish services under the routine home care level of care during the public health emergency as other patient care services. So as I mentioned, this is from the guidance that was published earlier in the pandemic. During my research for this presentation, I didn't come across anything that said to the contrary. However, I've not seen anything new, so I would advise that you check with your MAC to ensure whether it is still permissible to submit the telecommunications claims as separate from the hospice claims. Also, the temporary CMS emergency regulations regarding telehealth services for hospice did discuss what was required for a face-to-face encounter. So for initial face-to-face encounter, it must only be conducted via telecommunication systems for patients with an established relationship with the practitioner or a practitioner in the same practice under the same TIN. In other words, the patient needs to have already been an established patient of that physician. They can't be a new patient of the physician in order for that face-to-face visit to have been done using the telecommunication system. For recertification, CMS does allow the use of telehealth services, so it is okay if the recertification face-to-face encounter is done through telecommunication system. To allow the hospice physician or NP to do a face-to-face visit when its sole purpose is to recertify a patient for hospice services. They do specify that telecommunications technology must be the multimedia communications equipment that includes audio and video, permitting two-way real-time interactive communication between the patient and the distant site hospice physician or hospice NP. Now, I will note that the emergency regulations they're not explicit about this information, but that the CMS guidance that was published in conjunction with this did state that the expanded use of the waivers for telehealth services allows for these face-to-face encounters to be conducted over telecommunication systems. Next slide, Hunter. So this is an example that CMS provided back in April 2020 of an appropriate use of telehealth for the COVID-19 public health emergency. A terminally ill 85-year-old male with heart failure who had been receiving hospice services and then developed a fever, sore throat, and cough would be allowed to have telehealth services to include remote patient monitoring in order to prevent, the contamination of the care staff who would otherwise be performing this in person, since it was clear that the patient had COVID-19. So the remote patient monitoring allows for more expedited modifications to the plan of care in response to the patient's changing care of needs. Next slide. And Ashley will now talk about the security concerns.
Yes. Thank you, Mary. So now we want to go over some security concerns that arise in conjunction with telehealth and some things that you all should be thinking about, especially if you're utilizing telehealth services, but also you should be considering these things in general. As obviously HIPAA is still a concern for everybody, and as we have more of our employees working remotely or working, and you all have people out in the field utilizing their cars, and then you have personnel working from home as well. It's just very important to make sure you are dotting all your I's and crossing all your T's. So the same requirements apply for HIPAA for telehealth as same as regular face-to-face interactions and services. The security rule is really of particular importance in connection with telehealth services. And as a review for everybody here, and stick with me because I know HIPAA can be a little dry, but I just want to make sure everybody understands that the security standards require that both covered entities, so that would be a healthcare provider, the home healthcare provider or hospice provider, and their business associates ensure confidentiality, integrity, and availability of all electronic protected health information, or PHI, that the covered entity or the business associate receives, creates, maintains, or transmits. And the covered entity and the business associate may use any security measures that allow the covered entity or the business associate to reasonably and appropriately implement the standards as specified under the regs. And in deciding which security measures to use, a covered entity or a business associate should consider the following factors, which include the size, complexity, and capability of the covered entity or the business associate, and then also the covered entity or business associates' technical infrastructure, hardware, and security, software security capabilities. So this kind of allows for some scalability. You know, you need to take precautions in that, you know, that also correlate to your specific size and the type of business that you are running. Some additional things that you need to think about are your HIPAA risk analysis. You are required to conduct an accurate and thorough assessment of the potential risks and vulnerabilities to the confidentiality, integrity, and availability of electronic protected health information that's held by you as a covered entity, or if you're a business associate that's also listening today, business associates should be doing this as well. To do a risk assessment, you're likely going to need some assistance from your IT department, and you will also want to develop your risk assessment plan after you do an initial analysis with the help of your IT personnel. We definitely recommend documenting everything so that you're showing your progress towards meeting your goals as you're working through the process. You also need to have another safeguard in place for sanctions. You need to make sure you're applying appropriate sanctions against any workforce members that might fail to comply with any security policies or procedures of your covered entity, or a business associate as well needs to be considering that. You should also have somebody, it's not enough really generally just to put some policies in place and, you know, train everybody. You should put somebody in charge, we call it a security officer, in charge of making sure everything is going according to your policies and procedures. All of these things are getting done. Assigning that responsibility to someone really does make a lot of difference in ensuring that policies are being followed and the appropriate actions are being taken. So it's really important to have that person assigned and established, and that they understand what their specific responsibilities are. You should also have a termination for, oh, sorry, go ahead, Mary.
No, sorry, Ashley. I was just going to note, particularly since we're talking about telehealth services and telecommunications, which is obviously a new type of service that is being allowed by Medicare for the first time for home health and hospice. It's particularly important at this time to take the measures that Ashley is mentioning and have that security officer in place, because with all the changes that are coming, with the probably continued expanded use of telehealth services, we're just seeing an increase in the possible security risks that you're going to have, what with everyone having, you know, mobile devices that have cameras on it, and continued use of, you know, laptop computers with cameras. It's just, you're going to have more security risk as the use of telehealth services increase.
Absolutely. Absolutely. Thank you, Mary. And another thing you need to make sure, in addition to those sanction policies I mentioned earlier, you should also have some termination procedures in place so that you can handle any situations that arise. And I'm not only talking about, you know, termination due to possible non-compliance with your policies. I'm also talking about termination in regard to access. So if you do have an employee that leaves, you need to be able to terminate their access. Or if, for example, a laptop or something is stolen, you should be able to terminate access to that computer, and it should have, encryption and all of that on it as well. That's really important for all of your devices that might be walking around. If you have laptops, iPads, other tablets, mobile devices, all of those need to be encrypted to ensure that it's secure. And then they should also be able to be, remotely terminated, and you should have procedures in place for how that will happen if there is a employee that leaves or if something happens to a device. So
Yes.
in regards, oh, sorry, Mary, go ahead.
No, it's okay. I was just going to say, additionally, because of all of these concerns, it is important that you're not having employees use their own devices. So no employee should be using their own personal laptop or their cell phone to do any of the work for your agency, for the hospice. It should be that if an employee needs those devices, that you as the agency are providing that to them. And that will also further your ability to, terminate it, access in the need that you need to, and to make sure that it is safely encrypted, and that employees are also not using those devices for personal contact, for access of, social media sites, or for contacting friends and family outside of the workday.
That's exactly right, Mary. And some things that you should think about as you're thinking about your security risk assessment, the policies that you have in place. I want you to think about where you're storing your electronic protected health information, how it's received, how it's maintained, how you're transmitting it. You need to identify all of those different things so that you can see where your risks are. And you also want to identify your potential threats. And by identifying that first thing where you're storing it, receiving it, maintaining it, that's going to identify some potential threats for you as well. But other potential threats could be, your employees out in the field. Unfortunately, a lot of times, and we have some cases that we're going to get into in a little bit, but a lot of times when we see breaches happen, it's, not an outsider necessarily. It's somebody with keys to the castle. It's one of your employees that, unfortunately something happened and it caused a breach. So you need to identify the potential threats that include your employees potentially misplacing a device, or having printed out copies of PHI within their home. Is that permitted? Is that not permitted? If it is permitted, how are they destroying it? So all of those things are potential threats that should be identified. You then want to assess those threats and figure out security measures that you as the covered entity or the business associate can use to safeguard that PHI and make sure it's being used properly and destroyed properly. You're going to determine the likelihood of each threat occurrence in that risk assessment as well, the potential impact of each threat, and you're going to continue to document your process, document the results, and you need to be reviewing this risk assessment, risk analysis, and updating it periodically to make sure it's a living and breathing thing. It's not something you do once and then you put it in a cabinet and don't think about it again. It's something you need to constantly be thinking about. And if you haven't taken time to look at this since the onset of COVID, I highly recommend that you look at it now, because our world has just changed a lot over the last year. So it's really critical that you have policies that are reflecting ways that your company may have changed over the past year, and that you have procedures in place to safeguard you as a company, to safeguard that PHI, and to make sure you are able to respond appropriately if there is some sort of breach at your company. And some policies that you might want to consider, if you don't already have them in place, are responsibilities of your staff to safeguard patient information, what your data encryption requirements are, restrictions on mobile devices. And you can break these out. You can put separate restrictions on mobile devices that might be owned by you as a company, and restrictions on devices owned by staff. For example, as Mary said, generally discouraging your clients, your patients, sorry, your employees, oh my goodness, from using their own personal devices, and then having, a tablet or something that the company utilizes. And then you would have a policy in place that would restrict your employees from utilizing their own devices to transmit patient information, so that you have control over that tablet. You know that it has the encryption necessary on it, and then you have safe policies in place and safeguards in place for that tablet as to how we're going to shut it down and what employees can do and cannot do on that company-owned tablet. You also want to make sure you have a policy on changing passwords. I think this is really important, especially for mobile devices, for laptops, that you're constantly changing your passwords. People aren't saving passwords in case it falls into the hands of somebody else, so that it's, you know, it's essentially just, if it's a laptop, it's just like a brick that nobody can get into if it falls into the hands of somebody else. And you need to make sure that you're requiring the passwords be changed on a relatively frequent basis, which I know nobody wants to do because everybody has, you know, 900 different passwords, but unfortunately, it's really important to do that, especially when we're talking about possible access to protected health information. You also want to make sure you are identifying the penalties for a breach of PHI, and that you have a policy that's designating, as Mary and I were saying earlier, your security officer, who that person is and what their responsibilities are, so that they can refer back to that and understand what they are supposed to do to make sure they're carrying out your security rules appropriately. And another thing to consider here are business associate agreements. So if you haven't taken a look at your business associate agreements, I would highly recommend taking a look at your contract, identifying who all of your business associates are that may have changed. You may have added some new business associates over the past year. So take a look at that. Make sure that those are all accurate, up to date, they're all signed. You have them on file. Definitely something that if you just, you know, do once and don't think about, we highly recommend reviewing that and ensuring that those are all up to date. And as I also want to just, go ahead, Mary.
Reminder, just as a reminder, business associates are any contractors or outside people who will have access to PHI. So that does include the software providers that you use, the telecommunications systems that you may have adapted during this time period. Those entities are considered business associates. And so if you are currently using, you know, an email system, or if you're currently using a new video conferencing system, it is important that you have a business associate agreement in place with those entities, because they are your business associates, and in order to be protected under HIPAA, you need to make sure that they have signed that and understand what the safeguards that need to take place in order to protect your PHI.
That's exactly right. And Hunter, I think we can go ahead and move on to the next slide. There we go. So we have some potential HIPAA issues listed on the screen here for you. And I also just want to review what exactly, you know, a breach is. So a breach means the acquisition, access, use, or disclosure of protected health information in a manner that is not permitted, which compromises the security or privacy of the PHI. So if there is an acquisition, use, or disclosure of protected health information that is not permitted, it's generally presumed to be a breach, unless the covered entity or the business associate can demonstrate that there is a low probability that the protected health information has been compromised based on a risk assessment. And there are some risk factors that you can consider, which are the nature and extent of the PHI involved, including the types of identifiers and the likelihood of re-identification. And identifiers, you know, include names, birth dates, addresses. But there are examples out there where if you're in a small town and there's very specific information in a record, then, you know, it could be very easy to identify. So it just depends on your specific set of factual circumstances and what has been disclosed. So it's something you need to think about. It's not just, well, we just had, you know, a birth date and one patient note, so nobody can identify it. If you just have to think about your specific situation, because it may be identifiable in your area. You also need to consider the person who used the PHI or to whom the disclosure was made, whether that PHI was actually acquired or viewed, and the extent to which the risk to the PHI was mitigated. So what steps did you take? If the laptop was lost, did you terminate it immediately? Was access, never allowed because there wasn't password safe? So all of those things are things that you should consider. And again, this is just such a big deal. The unsecured mobile devices or phones, that's a really big risk area, I think, for all providers. And you need to make sure your staff really understands what your policies are here. You need to train them. You need to document that you're training them as well. That should be a part of your compliance training, that you've run over your HIPAA rules with them and that they have received that training and that they understand what is required of them, what they need to be doing. We also recommend that you have your notice of privacy practices, that you're updating that if you are using telehealth, to make sure that you're including telehealth information in your notice of privacy practices. That your patients are understanding the systems that you're using, the potential risks for that information, and that you aren't disclosing the information using the information except as permitted under HIPAA. So that's just something to consider if you haven't looked at your notice of privacy practices and you've been utilizing telehealth, and you may want to take a look and revise those notice of privacy practices so that they are up to date. Okay, and I think we can go ahead and move on to the next slide. Hunter?
There. Yeah. Just because one thing to note is that with the increased use of telecommunication systems, something that I guess I am personally guilty of doing is not necessarily updating my software when there are notifications. But you as an agency, as a business, should not be like me, and you should make sure that you are updating your software and your firewalls, because not doing so does make you more vulnerable to a breach. So you do need to make sure that when those updates come out, that you're not ignoring them and that you are implementing them as in accordance with what your IT staff says. So just be really careful to make sure that you're not allowing things to go out of date, because that's when breaches can happen.
That's exactly right. And now I think we're going to try to run through some cases with you all. If we could go ahead and move on to the next slide. Okay, so we've got a couple cases here that are fairly recent. The first one we have is related actually to a stolen unencrypted laptop. This was a hospice company up in Idaho that resulted in a $50,000 HIPAA penalty. This actually impacted fewer than 500 individuals, which I think is an important thing to note in this case. There was an unencrypted laptop. It was stolen from the hospice that contained the PHI of 441 individuals. The laptop belonged to a hospice nurse and unfortunately was stolen out of her car while it was parked at her home. So that, like I said, I mean, your employees, unfortunately, those are some of your loose ends that you have to ensure they understand what's required and that they're following those policies that you have in place. And that you have safeguards for your mobile devices like your laptops. In the event that something like this happens, because we hear about things like this all the time where laptops, just get stolen or they get lost, and you need to make sure that your laptops are encrypted, because unfortunately this laptop was unencrypted and had PHI of over 400 individuals. And I know this isn't telehealth specific, but in general, just thinking about this, I know having those patient files available on the computer, you need to be able to shut that down. And unfortunately, in this case, that the company didn't have they weren't having the safeguards in place where they could do that. So this was a breach, and a penalty, a pretty hefty fine of $50,000 was imposed on that hospice company in Idaho. And I know it's been a very tough year on all healthcare providers. So the last thing we need right now is a breach and then a fine imposed by OCR, the Office of Civil Rights, for a HIPAA violation.
And I will note the reason we included this case is because it was the first time in OCR history that they imposed a penalty fine for a breach that affected less than 500 individuals. So as you know, I mean, this case is about 8 years old, but it just goes to show that in that time, OCR is now looking at smaller breaches for possible penalty with fines. So it is important to not discount yourself as possibly being, vulnerable to HIPAA breaches and to penalties for said HIPAA breaches just because you might be a smaller hospice provider or a smaller home health agency. OCR doesn't really care. They want to make sure you are following the law and that you are protecting PHI.
That's right, Mary. And the next case we have here was a HIPAA breach at a national home health agency. Unfortunately, fines were imposed here as well. This is a pretty unique and interesting case. The operating center manager had created and maintained in her home the PHI of 278 patients that received services from the home health agency. Unfortunately, the operating center manager, her marriage was dissolving, and she moved out of her home from her that she shared with her husband. And when she moved out, she unfortunately left behind some PHI, and that was discovered by her ex-husband when he was going through some files. He stated that the PHI was stored under a bed and in a kitchen drawer. As a result of identifying this, her husband notified the Office of Civil Rights that he had been left in possession of the files, even though he was not authorized to view them. So, something to think about there. If you do have people working from home, if they're printing out files, you need to make sure that they are also able to destroy those files and that they are keeping very accurate tabs on that documentation if they move or if they go through a divorce. Unfortunately, like this individual, they need to make sure they're keeping track of that because it could lead to a breach. And I do want to point out that through the investigation that the Office of Civil Rights conducted, the fines were actually imposed on the home health company because it actually had policies in place that permitted certain employees to keep PHI in their home and cars. So, they didn't have appropriate safeguards in place, and OCR noted that, and that's why the fines were imposed here, because they, weren't addressing that situation in their risk analysis. That was just something that they permitted.
So explicitly allowed employees to have this. So it is also why we are recommending that, after this webinar today, take a look at your policies, because while it may sound like that sounds okay, a policy like that, as you see, was pretty damning and resulted in a almost $250,000 or over a $250,000 civil monetary penalty. So it is really important to make sure, especially if you, if you do not have policies that were tailored to your practice, if you printed them off online, go take a look. And then we do recommend that you hire some counsel to make sure you have a compliant plan and policies in place that actually reflect your practice and actually reflect the law.
That's exactly right. And something else to think about too, Mary and I have worked on a case where, a provider was utilizing a notepad to keep notes, and they were traveling around providing services. So if you have providers either at home providing services via telehealth, and they're keeping track of their notes on a notepad and then entering it into your EHR, or if you have people working at home that might be printing PHI, or even if you have people out in the field who may not, I know sometimes our EHR systems now, they won't let you move on to the next visit date if you haven't completed notes from a prior visit. So sometimes I know practitioners are utilizing handwritten notes and then entering in their notes in the EHR system later. What's happening to those handwritten notes? Because we don't want to lose those handwritten notes. We need to make sure if people are doing that, those notes are being destroyed, and that you need to make sure you're addressing that in your policies, because that can be a loose end that can cause a lot of problems for an agency if something were to happen to that notebook. And we have unfortunately seen cases where that has certainly happened. And one more case here for you is a UK-based telehealth app, unfortunately, experienced a breach of its general practitioner platform, where users were actually able to access videos from other patient appointments, which I'm sure if you have had any telehealth appointments over the last year, it's kind of terrifying to you. It is to me to have some, person that you don't know watching a video of your telehealth appointment with your doctor, but that's what was happening here. A patient actually announced this on Twitter, that they were able to view videos from about 50 other patient appointments. So this is just, a nightmare for the company, obviously. I mean, this is a company that's trying to provide a telehealth app for practitioners to utilize, and there's this ability to view visits from for other patients. So it's very important that if you are using some sort of software to provide telehealth visits, that you understand what they're doing with those videos. Are they saving the videos? Are they destroying them? Are they recorded? Are they not recorded? You need to just make sure it's a highly vetted service. And it's just another thing to consider if you are utilizing telehealth services, that that's a business associate if you're using an app or something like that, and you need to make sure you've got a BAA in place with them. What are they doing to safeguard your information? And unfortunately, in the world we live in today, that's something we've got to consider, because you don't want one of your patients or one of your patients' children to put out on Twitter or Facebook that they can watch everybody's visits online. That would be a huge PR nightmare for any company to deal with, on top of everything else we're already dealing with during this pandemic. I think, unless Mary, you have anything to say about that last case, we can go ahead and move on to our last slide, or to our second to last slide, I guess I should say. So thank you for sticking with us today. I know we have provided you with a lot of information. Some of it was a little dry, and unfortunately, that's just the nature of some of these rules. But it's really important information, and we know that while all these new rules, all this new technology we can utilize, it's really important that if you are using it, you're using it appropriately. We knew that audits were going to be coming, as Mary talked about earlier. They're already underway. So make sure you're updating your policies and procedures, you're doing that risk analysis, you understand what the rules are if you are using telehealth, so that you are compliant and that you are prepared if you do receive notice of an audit, that you know that you're already doing everything appropriately. And if you don't understand all the rules, I recommend reaching out to somebody who can help advise you and make sure your policies and procedures are up to date. It's really critical that you don't leave those loose ends out there until you have an issue, and then you're trying to deal with it on the back end, which is a much more stressful situation.
Yes, and particularly because telehealth services, are now being allowed in more circumstances than they previously were prior to the pandemic. It is important to keep up with that information, to make sure that you, especially if you are utilizing telehealth services, to make sure that you're not using them outside what is permitted and payable under Medicare, because that is what's going to come up in these audits that we're going to start seeing. Fortunately, Medicare, CMS did take a break during part of the pandemic from their usual activities of auditing and taking a look at, provider records. But we are starting to see them come back in, and we're starting to see audits being conducted. So it is just really important that you fully understand what you're allowed to do and what you are allowed to provide via telehealth services, via telehealth communications, because we want to make sure that you're not starting to become too reliant on these services and you're using them in the incorrect manner. Which is why we do kind of end this presentation with advice to use it sparingly, just because things are still so up in the air. It is a little unclear, and while this public health emergency is going on, we are concerned that we're going to start seeing an uptick in audits, in the coming couple of years after this emergency concludes, because, unfortunately, there are bad actors out there who will take advantage of this crazy time to commit fraud. and HHSOIG is going to investigate everyone with that mindset.
That's exactly right. And Hunter, I think we can move on to our last slide and let us know if there's any questions from anybody. We're happy to try to address those.
We got a few. Will the audits include the doctor's face-to-face encounters for home health? That's what they didn't give too much. I guess they didn't give too much context there, but
so I would generally say yes, because, I mean, in general, face-to-face encounters, and Mary, you can speak to, specifically the telehealth, but in general, yes, an audit of a home health company is going to involve a review of your face-to-face encounters.
Okay.
So I'm. Oh,
go ahead. Sorry.
Hunter.
You can go ahead.
No, I was just going to say, I'm sure that question was being asked in conjunction with the January 2021 audit that was announced by HHSOIG with the use of the Section 1135 telehealth waivers. I do believe that is going to be, they're going to probably be taking a look at the face-to-face encounters as well, because those waivers expanded the providers who are allowed to use telehealth services to include some like non-physician practitioners who weren't previously allowed to use telehealth services. So yes, as Ashley said, it is likely that they're going to be taking a look at the face-to-face encounters when they're doing this audit.
All right. Another is, someone says, you recommend to use sparingly, but what are the reasons that they're allowing telehealth? Clinicians wanting to minimize exposure? It's kind of, I apologize, 1 second, it's... Yeah, clinicians not wanting to minimize exposure, family wanting to minimize exposure, medically fragile client. How is an auditor determining whether telehealth is necessary if it's written into the POC? If it's not written, determining if it's not necessary if it's written into the POC. So I guess they're wondering, basically, how did they know if telehealth was necessary? The auditors.
Yeah, so it is our understanding that if it is explicitly written in the plan of care from the physician that telehealth services are needed, that should be covered. That should be sufficient evidence that this was, ordered by the physician. The reason we are saying to use it sparingly is because we know that telehealth services are being allowed in kind of larger circumstances, but primarily our concern is that people may have started using telehealth services outside of what is permitted by Medicare. So if, for example, a skilled nurse, instead of going into the patient's home, just conducted a video conference with the patient and, tried to check in with them and provide education that way, that may or may not be covered under the regulations. And so we just wanted to make sure that if you are using telehealth services, that you're very aware of the limitations of this new expansion and you're aware of explicitly what is permitted.
Okay. And then final question, if a clinician has to use FaceTime, would a business agreement be needed with Apple? No PHI is transferred over session, it's just the video.
Can you say that again? So
if a clinician has to use FaceTime, would a business agreement be needed with Apple? No PHI is transferred over session, it's just the video.
Yeah, so you shouldn't be using FaceTime. FaceTime is not a HIPAA protected form of video communication. I know that during the public health emergency, they are, OCR has said that they are going to, use their discretion in the event that people have been using FaceTime. But now that we're over a year into this public health emergency, at this time, I would definitely recommend no one be using FaceTime. And unfortunately, the use of the video to have a visit with a patient, that is you are exchanging PHI over that video.
PHI, yeah, there would be because the patient's face would be there, and that's something that can identify the patient, and the audio is going to come from somewhere as well. So I would just, I would be leery of doing anything over FaceTime and making sure you're using platforms that are HIPAA compliant.
Yeah.
And then, yep, and then that's it. Just the last one was more for me. Yes, this recording will be sent out, or a link will be sent out via email to our website, which will host this recording. So that should be posted shortly. But I don't have any more questions. And yeah.
Okay. If anybody has any questions that you didn't get a chance to ask, Marion, my contact information is on the screen. Feel free to shoot us an email, and we're happy to speak with you in more detail. Otherwise, thank you, Mary. Thank you, Hunter, for today, and thank you to TAC for sponsoring and providing us the opportunity to speak with you all today.
All right.
Yes, thank you.
Thank you, guys. Have a wonderful day. Bye-bye.